Welcome, everyone. Thank you for joining us for today's member-only webinar, COVID-19 Preparedness, What to Consider and What's Being Done. My name is Steve Lamar. I'm President and CEO of the American Apparel and Footwear Association. A quick housekeeping note before we get started. If you have any questions during the presentation, please type them into the question box in your GoToWebinar control panel. I will bring them up during our Q&A portion following the presentation. And if you experience any technical difficulties throughout, please contact GoToWebinar support at 1-800-263-6317. That's 1-800-263-6317. As AAFA members, you gain unparalleled access to sources, tools, and special interest committees that deliver exclusive insights on regulation and policy, networking, and collaboration opportunities. We have a lot of information to share, so let's get started. I'm delighted to be presenting to you today along with Nate Herman, who's our Senior Vice President of Policy at AAFA, and Dr. Ben Schwartz, who is the Director of the Division of Population Health and Epidemiology at Fairfax County for the Virginia Health Department. Dr. Ben Schwartz this division conducts surveillance for communicable and non-communicable diseases, investigates disease outbreaks, uses data to identify significant and emerging health challenges and disparities in the Fairfax County population, collaborates in developing and testing solutions, and supports monitoring and evaluation to facilitate program involvement, program improvement and learning. Dr. Schwartz is trained in pediatrics, infectious diseases, and public health. He started his public health career at the Centers for Disease Control and Prevention, where he served for 22 years in communicable diseases and immunization positions. He led the global health team at CARE, a non-governmental organization, for 5 years, and spent 3 years as Deputy Director for Communicable Diseases Control at the Los Angeles County Department of Public Health before coming to Fairfax County in January 2018. I think we can all agree that Ben has very, very unique and very valid perspective and insight on the crisis that we're facing today. Attendees of this webinar will understand the current status of the pandemic, evaluate ways to slow the spread of the virus, and learn about some of the tools and research that AAFA has made available to members. Dr. Schwartz, with that, why don't we turn it over to you and hear what you have to say. And Dr. Schwartz still, so if you're still on mute, maybe you can come off. A second, we're just trying to make sure he's off of mute.
Steve, you're breaking up, right? So this is Nate Herman here at AFA. Why don't we turn it over to Ben to begin your presentation? Ben, why don't you go ahead? Ben, if you could take yourself off mute and you can go ahead and start.
Hi, can you hear me now?
Yes.
Okay, I'm doing this with the computer audio. The phone didn't seem to be working well. So please, whether this is good sound quality. Can you hear me?
Ben, are you able to press? And I apologize to everyone for the technical difficulties here.
This is Dr. Schwartz. Can you hear me now? Hello?
Yeah, we can hear you. Go ahead.
Okay, I'm so sorry. These are problems with this.
I'm sorry, we're still having, I don't understand why.
Let me try calling you from my cell phone and see if that makes a difference.
Maybe we're using here. Hey, moving for you.
Hello? Can Hello?
Hey, Ben, I don't know.
Hello? Me? Okay. I'm going to, I hope people can hear me. What about COVID-19 preparedness, what to consider, and what is being done? This presentation to begin with the disease overdiagnostic situation. We have to recognize that this situation is changing day to day, and with our best current knowledge, and as information changes, we will provide updates. Coronaviruses have come in several coronaviruses a long time to cause severe disease in people. And this had already happened with SARS in 2002, MERS in 2012, and now COVID-19. Coronavirus is spread through coughing, sneezing, and close personal contact, and symptoms generally start 2 to 14 days after exposure. The novel coronavirus, COVID-19, was first recognized in persons at a Wuhan. The COVID-19 virus most likely initially came from bats, and an intermediate animal host, the pangolin, has been proposed, but has not been proven. COVID-19 stands for coronavirus disease, which emerged in 2019. It's very actual has
200,000, with many more deaths than are shown here. Most of the cases have occurred outside of China now, with Europe and the United States being epicenters of disease, along with Iran. And cases in the US, again, are a couple days behind. And now there are more than 7,000 US cases occurring. This global map shows the countries where coronavirus has been identified. According to the World Health Organization, more than 150 countries have reported coronavirus cases. And those countries that have not, it is probably more a failure of diagnosis rather than the absence of disease. There are CDC travel notices for a number of countries around the world. Level 3 travel warnings exist for Europe, the UK, Ireland, Iran, South Korea, and China, and a level 2 travel advisory for Japan. Note that these advisories in place longer than perhaps the diseases for Korea are as high a rate as in many other countries around the world. So look at these travel notices, but also go to the World Health Organization website where they have a situation update, and each day you can see how many new cases have been identified in each country around the world, and keep better track of where the hotspots are globally rather than relying on the CDC travel notices to do so. This map shows where cases have occurred in the United States. It also is a couple days out of date, but the hotspots in the US have occurred in Seattle and Central California and New York City, but cases have occurred in every other state. And although West Virginia was the one outlier, they now have had a case, so it has occurred in each of the 50 states plus DC. According to the Centers for Disease Control and Prevention, the immediate risk of being exposed to this virus is still low for most Americans, but as the outbreak expands, that risk will increase. There is an elevated risk of exposure in people where there is ongoing community spread of the virus, as well as among healthcare workers caring for patients with COVID-19, close contacts of those individuals, and travelers returning from affected international locations where there is community spread. COVID-19 spreads predominantly person to person via respiratory droplets that are produced when an infected person coughs or sneezes. And generally, this means that if people are 6 feet or more apart, they are not at risk of getting COVID-19 because those large respiratory droplets, rather than remaining suspended in the air, will fall out of the air due to gravity. So if you're 6 feet away from someone else, generally, you're safe and are unlikely to get infected. Unlike some other respiratory diseases, COVID-19 does not travel through ventilation systems. So it's really that close contact which puts one at risk. There also are some emerging data on the survival of the virus that causes COVID-19 on surfaces. The survival on a surface depends on the type of surface and on environmental conditions. As you can see on the right of this slide, the longest survival of the virus occurs on stainless steel and plastic, with some virus being detectable as long as 80 hours after it was initially deposited on the surface. However, it's important to communicate that virus survival time in and of itself does not imply infectiousness, and contact with infected surfaces is not thought to be the primary mode through which COVID-19 is transmitted. However, it does emphasize the importance of environmental sanitation, and SARS-CoV-2, which is the virus that causes this disease, can be killed by any of the disinfectants on EPA List N. And the website for this list is shown on this slide. Now, these are not some obscure or hard to get disinfectants, but they include things like bleach, things like Clorox wipes, and many of the common disinfectants you'll recognize are on this list. The symptoms of COVID-19 include fever, cough, and shortness of breath. Other common symptoms may include fatigue, muscle aches, and loss of appetite. Only about 15% of those who are infected will develop serious illness such as pneumonia and may require hospitalization, and about 5% or perhaps a little bit less may require intensive care. About 2% of people who are infected with COVID-19 have died of their illness, but some studies suggest that this is overestimated because of the quality of the healthcare services that we have in the U.S., and also because we're not detecting all of the cases of disease, so therefore we're overestimating the risk of death. However, you can see that COVID-19 is much more fatal than is seasonal influenza, more fatal than the influenza pandemics in 1957, 1968, or the pandemic in 2009, and is most comparable with the influenza pandemic from 1918, which is the most severe pandemic that we have had in modern times. The highest risk of death is in the elderly and in persons with underlying disease. And so these are the groups at increased risk for severe or fatal infection: older adults, persons who have underlying diseases such as heart or lung disease or diabetes, people who are immunocompromised from disease or medication, and many more people now are taking immune system blocking medications for a variety of autoimmune disease. So understanding if your medication is immune compromising is important. And then pregnant women, all increased risk. One of the questions that we frequently get is whether asymptomatic people, people who are not ill but infected, can transmit this infection. And first off, it is unknown how many people have COVID-19 who do not develop any symptoms of illness. Obviously, someone who is not ill generally is not being tested. But we do have information from one of the cruise ships where there were many infections that suggested that about half of the people who were cultured and who were tested and tested positive did not have symptomatic illness at the time they had the positive test done. There also are several family clusters that have been reported where it appears that someone had no symptoms but spread infection to their family contacts. Nevertheless, transmission by asymptomatic people is unlikely to occur because those who are asymptomatic probably have a lower level of virus in their respiratory tract, and also they are not coughing or sneezing, and therefore less likely to spread the respiratory secretions and to get other people ill. Can we predict what COVID-19 is going to do in the future? Will this continue to spread, and how bad will it be? And certainly we cannot make predictions with any high confidence level because of how much we don't know. But perhaps asking what will happen in the future is not the important question. It's not what we can predict, but rather it's what we should be planning for. Public health measures alone are unlikely to control the global spread of this disease. Absent a vaccine, the measures to stop disease spread include isolation and quarantine, social distancing, and personal protective behaviors. With SARS, the other coronavirus infection that emerged in 2002, these measures were successful and led to the eradication of infection. But the reason why they worked was that people who have infection did not spread disease, until several days after illness began. And this gave the public health authorities several days to implement measures such as isolation and quarantine of contacts. Unfortunately, with COVID-19, this is not the case. With COVID-19, people who don't have symptoms or who just became ill still can spread infection, and certainly the infection has spread to many more countries, including those where applying public health measures is difficult. And therefore, we would predict that the global spread of COVID-19 will continue. And that's not stepping out on the ledge. That I think everyone will know is a pretty solid prediction. So instead of what can we predict, what is it that we should be planning for? And we should plan that disease will continue to spread globally, that community outbreaks will occur in the United States, and both of those already have occurred. We would plan for disease occurring in waves, most likely in the spring and fall and winter, and that in any community, the wave will likely last somewhere between 6 weeks and 3 months. Based on our experience with influenza, we should plan for up to 20% of the population being infected, and up to 2% of those infected may die. And then finally, we should plan for a situation where vaccine and antiviral drugs will become available eventually, but certainly not by the time of the first pandemic wave. And that too seems to be borne out by our current experience. This slide shows what disease waves look like, and it comes from the 2009 influenza pandemic. Each of the 3 curves is a different geographical area. So in blue is Houston, in red Milwaukee, and in green is New York State. And there are several messages that I'd like to communicate from this slide. First, that communities are likely to experience multiple waves of disease. So in the winter and early spring of 2009, there was a wave of disease in Houston. It went away over the later spring and the summer, but in the fall of that year, an even larger wave occurred. Similarly, in New York and Milwaukee, there the first wave was a little bit more delayed, perhaps occurred during the summer, but again, you can see that the fall to winter peak was much higher. These smaller initial waves sometimes have been called herald waves, with larger waves of disease to come. And so this could be what we're looking toward with coronavirus as well. So let me move from a description of the virus and the illness it causes to how we can respond through containment and community mitigation. The U.S. has implemented a number of measures as part of our response. A U.S. public health emergency has been declared, travelers have been monitored, diagnostic tests developed, and laboratory testing is expanding. There has been coordination of surveillance with state and local health departments, as well as efforts around vaccine development and clinical trials of antiviral drugs, and guidance for pandemic preparedness. When a new disease emerges, the initial response to that disease is something that we call containment. The goals of containment are to prevent the introduction of illness into a community, to prevent the spread within that community, and ideally to eradicate the infection. And containment strategies include travel restrictions, individual case investigations, and isolation and quarantine. When containment fails, or when containment becomes infeasible because of a large number of cases, then the approach that's taken is one of mitigation. And the goals of mitigation are different. They are to delay and to slow the spread of infection in communities, to reduce the peak attack rate of illness, as well as the overall number of people who are affected, and to reduce community disruption. In other words, maintaining critical services like healthcare and public safety. Mitigation strategies include a range of strategies called non-pharmaceutical interventions that we'll talk more about in a couple minutes, as well as continuity of operation planning, and when available, vaccines and drug treatment. So currently, our containment strategy includes interventions with travelers. Those from China and Iran are directed to a limited number of airports. They undergo a health assessment, and each one of those travelers is contacted by their local health department for follow-up, risk assessment, self-quarantine, and monitoring. Travelers from other countries where there are travel warnings, including South Korea, Italy, Europe, UK, and Ireland, all receive either exit screening or entry screening on arrival to the US, and they are told to stay at home and away from others for 14 days, but there is not active health department monitoring or follow-up for these individuals. A containment strategy relies on testing for the virus so that we can identify cases, and each one of those identified cases can then be followed up, investigated, and isolation and quarantine implemented. So at this phase, we really depend a lot on diagnostic testing. Unfortunately, those tests have not been as widely available as we would have hoped. These tests detect specific viral RNA from a nasopharyngeal swab specimen. Testing now is available at state health laboratories as well as a number of large commercial labs, including LabCorp and Quest. But there are challenges to the availability of diagnostic testing. First, there's a lack of material to obtain and process the specimens, particularly viral transport medium. Secondly, community physicians may lack appropriate personal protective equipment and don't want to do tests for fear of becoming ill themselves and needing to be out of work and not being able to provide needed medical services. And this creates a high burden in emergency department settings, and so many EDs are also limiting the amount of testing that they're doing. The priorities for testing include patients who are severely ill, those who are at high risk for severe disease, persons in high-risk situations like residents of long-term care facilities, as well as essential service providers. So here is a schematic of the containment and mitigation strategy. So containment occurs first, and then there is a period of time during which containment and mitigation take place together, but over time we shift primarily to mitigation. And this is about where we are right now, implementing both containment as well as mitigation strategies. So let's go to community mitigation. And the goal of mitigation is to do what we call flatten the curve. So what disease might look like in a community with a pandemic virus like COVID-19 is shown in that solid purple curve. If mitigation activities are implemented effectively, what we can do is we can shift the curve to the right. In other words, we can delay it, and we can also reduce the peak, reduce the number of cases that occur each day, as well as the total number of cases in the community, helping us preserve essential services. The mainstay for mitigation in the absence of a vaccine is what is called non-pharmaceutical interventions. And these NPIs can be done by individuals, so personal interventions, community interventions, and also environmental interventions. Personal NPIs include good hand washing for 20 seconds with soap and water, or with hand sanitizer containing at least 60% alcohol if soap and water are not available. Covering coughs and sneezes. Keeping from touching your eyes, your nose, or your mouth. So if you have COVID-19 on your hands, but you keep your hands away from your face, you will not inoculate yourself and you will not become infected. So this is really something important to emphasize, keeping from touching your eyes, your nose, and your mouth. Social distancing, which I'll talk about some more, and then voluntary home isolation and home quarantine. At the community level, social distancing is also a key strategy, as well as dismissal or closing of schools, modification of work practices, canceling mass gatherings, and cleaning of environmental surfaces. Social distancing, as I've already mentioned, means being about 6 feet or more away from other people. And social distancing strategies might include shopping during off hours or buying online, teleworking, limiting face-to-face meetings or conference calls, rearranging school classrooms and avoiding crowded places. It's important to emphasize that while we call this social distancing, what we really mean is physical distancing. And we have to be careful that social distancing does not mean social disconnection. So talk to people, but talk with them from a distance. Talk with them on the phone. Have a video conference. So we don't want to isolate ourselves from others socially, but we do want to maintain that distancing physically. Dismissal or closing schools is effective in influenza pandemics because children have the highest attack rate of influenza infection, and spread of disease among children often precedes broader community transmission. For COVID-19, however, the rates of disease in children seem relatively low and disease severity is less. Nevertheless, due to its potential benefits and reduction of community spread, most schools in many communities are now closed. Of course, closing schools creates challenges. So we're not sure if everybody is able to do distance learning. Many people rely on the school setting for meals, for breakfast and lunches. And there is an impact on the workforce as parents need to stay home to care for their children. There has been widespread canceling of public gatherings, and I'm sure you've all heard the president suggesting that all gatherings of greater than 10 people be stopped. In Virginia, where Fairfax County is, our governor and health commissioner issued a public health emergency order to enforce this 10-patron limit at restaurants, fitness centers, and in theaters. But it's important that we don't focus only on what the numeric limit is, but rather on the intent of limiting gatherings. And the intent is to ensure that people have the ability to socially distance. We want to emphasize the protection of high-risk individuals so that people who are elderly or immunocompromised, we may want to make sure that they don't attend meetings, even if there are fewer than 10 people. And the need for protective behaviors is important at all times, regardless of the number of people who may come in contact with each other at some gathering. So let's move now to business preparedness. And I'm not going to talk about financial relief for businesses or for employees, because you know the financial situation and the financial consequences on your businesses much more than I do. So as a public health person, I'm going to focus on the health issues. However, you're certainly aware that there is pending legislation in Washington, as well as actions being taken by state governments around the country to mitigate the impact of the pandemic on businesses. And there are a variety of resources that may address some of your needs. For example, for small businesses, there are assistance programs that are ongoing and more that are likely to be implemented. So please use your contacts and your resources to address the issue of financial relief from the pandemic. But let's go back and talk about the disease impacts of the pandemic on your business. Those impacts have been highlighted, and ways to mitigate those impacts have been highlighted in a number of different documents. For example, this document on guidance on preparing workplaces, which comes from OSHA, the Occupational Safety and Health Administration. They talk about business impacts coming from absenteeism from illness, due to caring for ill family members, caring for those who are home from school, as well as fear of the workplace. In a severe pandemic, the estimate may be that as many as 40% during a large pandemic wave may be absent at some point during that wave. There will certainly be changes in commerce, including reduced demand and in how people shop, and then certainly supply and delivery disruption with reduced shipments from affected areas and decreased production. So businesses need to develop a plan, and we advise everyone to develop a written plan rather than a notional preparedness and response plan. I had the opportunity to speak briefly at the AAFA board meeting that was a few weeks ago, and I asked the people on the board who were attending the meeting to raise their hand if they had a preparedness plan, and only one of the people in the room raised their hand. Now, maybe there were more preparedness plans, and it's just not the right thing to do to ask a chief executive officer to raise their hand. But what it said to me was that there was still a lot of preparedness that needed to be done in your sector. And I hope that process has started at all of your businesses. When you develop a plan, think of the plan as being phased and layered. And those are two important words that CDC emphasizes again and again in its pandemic preparedness documents. So consider the phase. Consider situations when disease in a community is limited and the situation when that disease is widespread. And then layered. As the situation worsens, add layers to your response. For example, when there is limited disease, you may decide that older or other employees with high-risk conditions may continue to work. But during a large outbreak, you would want to modify their roles or let them stay home or work in a setting where they can be safe from the transmission of disease. In your plan for the continuity of operations and identify what functions are less vital and could be stopped during an outbreak. Plan for succession if key leadership is absent and think about staff cross-training. Get the authorities necessary in order to implement required HR measures, which often will mean work with your unions. And then finally, plan to keep your employees safe and healthy. A way to improve employee safety in the workplace is through what OSHA calls a hierarchy of controls. And that is, they look at engineering controls, administrative controls, and changes in behavior. And so in this OSHA document, they talk about personal protective equipment, but more broadly, these are work practices and behaviors that are exhibited by employees. Engineering controls include things like increasing ventilation rates, installing physical barriers, particularly in customer-facing areas, so that if you can have a plastic or a glass barrier between your employee and the public, that's going to decrease their exposure to respiratory secretions. Or similarly, install a drive-through window for customer service. Administrative controls include enabling workers to stay home, discontinuing non-essential travel, and developing an emergency communications plan. And then safe work practices. This is behaviors that people can undertake. Include enabling personal hygiene and enabling social distancing. And I'd like to emphasize the word enable. When I hear many people talk about pandemic preparedness and response, they talk about encouraging. So we want to encourage people to stay home. We want to encourage people to wash their hands. We want to encourage them to cover their costs. But encouragement alone often is not enough. If someone doesn't have paid sick leave, telling them to stay home when ill is unlikely to be effective. If there is not soap or hand sanitizer, telling them to wash their hands is likely to be ineffective. And if there are not tissues, asking them to cover their coughs may not be as effective. So it's important not just to encourage, but to make sure that you are enabling the behaviors that will stop the spread or slow the spread of this disease. So there are 5 key strategies to reduce illness in the workplace: individual protective behaviors, staying home from work when ill, social distancing, canceling gatherings, and enhanced environmental cleaning. And I'm going to go through each of these 5. So individual protective behaviors: reduce physical contact, stop shaking hands, use hand sanitizer or soap and water, have tissues and cleaning supplies available, and post signs as reminders of protective behaviors. The sign shown here is labeled for Fairfax County, but CDC has the same signage that you can get off of CDC's website. In terms of staying home from work when ill, expand your sick leave policies and implement leave policies that allow an employee to stay home with an ill family member. Facilitate telework. And during an outbreak, that is, again, part of the phased and layered approach. So during a large outbreak in the community, you may want to screen employees to see if they have fever or other respiratory symptoms before each shift. And if someone is ill, if they have fever or symptoms, send them home. Do not have them in the workplace. Social distancing: change the work environment so that workers have more space. Stagger work schedules and decrease social contacts in the workplace, limiting in-person meetings or perhaps closing break rooms so that people don't congregate. Cancel gatherings, eliminate staff meetings or after-work functions, trade shows and conferences, and postpone any non-essential work travel. In terms of environmental cleaning, increase the regular disinfection of all hard and frequently touched surfaces with a List-N disinfectant, and increase ventilation, opening windows or adjusting air conditioning. I put that in parentheses because this is something that is recommended in some places. I haven't seen any hard scientific evidence for its effectiveness, but it may be helpful, and so that's something to consider. And then finally, support the preparedness efforts of your key partners. If you have the ability to plan and prepare, recognize that some of your business partners may not have that ability and could use your assistance and could take from your pandemic plan in doing their own plan and in their process. Finally, I think it's really important that we consider the needs of the entire workforce. And in many places, you may think about your employees, but forget about the contractors who clean your building or others who may come into your facility but are not on your payroll. So consider employees and contractors who have physical disabilities, those whose primary language is other than English or who may not have paid sick leave, and employees and contractors who are economically disadvantaged, who are likely to live in crowded settings and use public transportation, etc., are likely at higher risk than the rest of the population, and consider their needs as well. In retail strategies, all of these approaches that I've mentioned are important to implement, and there are others. So use online transactions where possible. Consider if you can book appointments or do scheduling to stagger the customer flow, and follow guidance around limiting attendance at large gatherings, including managing the ingress, egress, and lines within your establishment, or people who are at the entrance waiting their turn to come in. And again, in parentheses, because this is not documented to be an important issue, but some have mentioned it, you may want to reduce handling of cash. Many people have asked the question, should I wear a face mask? CDC does not recommend that people who are well wear a face mask to protect themselves. There are two reasons for this. First, face masks are just not that protective against a respiratory virus. And there are a number of studies published in the medical literature which show that the protective effectiveness of face masks is limited. In addition, face masks are in short supply, and we want them to be available for the healthcare community and for use in settings where they are more needed. Face masks can be used and are important for people who have symptoms of respiratory illness because a face mask will trap the respiratory particles that may otherwise come out into the environment from coughing and sneezing. So if you have one face mask and the choice is, do you put it on yourself or do you put it on someone else who is coughing or sneezing? Put it on the person who is ill. N95 respirators, which are a higher level of respiratory protection, are even less common than face masks and need to be reserved for people who are taking care of a patient with COVID-19 in close settings. And then there are more personal protective equipment recommendations for healthcare workers, EMS providers, and law enforcement. I mentioned briefly the disparities in the risk of illness and consequences of the pandemic, but I'd like to emphasize it again. So people who are in disadvantaged communities, either in the U.S. or internationally, and I know many of you have international businesses, so people in disadvantaged communities live in more crowded settings, they are more likely to rely on crowded public transportation, are less likely to have a job where they can socially distance, are less likely to have paid sick leave, and also less likely to have easily accessible sources of medical care. As a result, illness in this population is more likely to occur, and the consequences of infection are likely to be more serious. So I think it's important that we all think not just of ourselves, but of our entire community and what we can do to mitigate the impact on that entire community. And here just is an illustration from the U.S. Bureau of Labor Statistics of disparities in sick leave by occupation. And you can see that people in the service sector and construction, extraction, and farming, that fewer than half of them have paid sick leave. In production and sales, it's less than 2/3. And so think about the entire workforce and their ability to take action that will mitigate the pandemic spread in your workplace as well as in the community. There are a number of resources and a number of websites that you can look at for more information. CDC has a lot of guidance in many different areas, and so certainly look at the CDC guidance. And I'd like to thank you. I'm sorry for some of the difficulties with the sound at the beginning. I hope you've all heard this, and I'm happy to answer questions.
Thank you, Dr. Schwartz. That was a very informative and comprehensive and also very depressing presentation, but one that was good for all of us to hear and learn from. So one of the points you mentioned in terms of what people should be doing, I did want to note that the American Apparel and Footwear Association at our own headquarters has implemented many of those provisions. We are all on work from home, a liberal leave policy, and so on and so forth. So with that, we have a few minutes for questions. So I'll open up with a question. This looks like a question actually for AAFA. What resources and actions has AAFA been taking? So the first one I want to answer that is that we have put out and noted by you, Dr. Schwartz, what response you got at the AAFA board meeting is that AAFA has published a checklist of recommendations as companies develop plans to deal with COVID-19. And that checklist is updated on a weekly basis. And so that's something that's a member-only resource we encourage everyone to check out. In addition, we've also been conducting a weekly survey to see how the COVID-19 is affecting our members and companies in the industry, from the supply chain to your retail business to your headquarters operations and everything in between. We are sharing the results of the survey and other detailed information, such as what Dr. Schwartz provided and weekly member updates. And we're very active through our committees in sharing information as well. And finally, even though Dr. Schwartz said that's not his purview, we are working on policy recommendations to implement liquidity through tax credits and tariff relief. And we've also asked U.S. Customs and Border Protection to delay tariff payments that are due, in many cases for many of you tomorrow, but are due on a monthly basis for all of you. And finally, we'll be developing a dashboard where we can, all the updates we're providing weekly will be in one location so that you can get all that information. So with that, let's move to some more questions. And there's a few here for Dr. Schwartz. So I'll start with the first one, Dr. Schwartz. We are getting questions from consumers regarding ensuring our products are not contaminated. What are methods we can use to help alleviate these concerns? Is it safe to assume the surface is free of contamination, given the days that you previously communicated? I guess this is for a product being sold by our members to consumers and the concerns expressed by the consumers on whether it's okay to touch those products. So,
yeah,
Dr. Schwartz.
There is absolutely no evidence that this disease has been transmitted by any products. Certainly materials, cloth, soft products, the virus survives only for a short period of time. It dries out rapidly, and that's why, for example, you sneeze into your sleeve or you cover your nose with a tissue, because the virus will not remain viable on cloth or on soft surfaces for an appreciable period. On packaging, on plastics, which was one of the substances that they studied in this investigation, it could survive for 3 days, but again, is likely to be actually infective for a much shorter period. And given the supply chains and businesses, and given how long it takes to ship a product to the customer, to the retail location, I think it's safe to say that transmission of infection from products is highly, highly unlikely.
Thanks. So the next question is, what can we do to protect workers in our distribution centers here in the United States? And these are the warehouses where we're taking inventory and moving product to our customers throughout the country.
Yeah, so I'd advise a few things. First, to the extent that you can socially distance in a warehouse, you should be doing that. I don't know how close together people need to stand or whether you can modify that so that they are a little bit further apart. Have people wear gloves, and what wearing gloves will do is it will keep their hands protected from getting contaminated. But also, I think people are probably more reluctant to put a rubber glove in their, to rub their eyes, their nose, or their mouth with a gloved hand than a hand without a glove. So it kind of serves as a reminder. Have hand sanitizer or hand washing stations available, and really remind people to wash their hands frequently. So in a distribution center, people are going to be touching all kinds of surfaces, and having them wash their hands again, I think, would be something that is prudent to do. And make sure that people who are sick are not at work. And I can't emphasize this enough because, many people, just today, there was a facility in Fairfax County where there was a case of disease, and one of the employees at that facility went to work and said they just had a low-grade temperature. And so you have to really emphasize to people that any fever or respiratory symptoms is enough for them to stay at home and not come to work, because the consequences of them working could be disastrous for a business.
Thank you. Okay, so the next question is, what should an employer do if a worker tests positive for the virus and prior to testing positive have been working with other employees in your company?
Yeah, that's a really good question. So the person who tests positive should be isolated at home and away from others in the household for at least 7 days, and until symptoms have been gone for 72 hours, until no fever for 72 hours, and until the other symptoms have improved. Those people who they came in close contact with, depending on how close the contact is, you could either ask them to self-quarantine, which means the contact would stay home for a 14-day period, during which time illness might develop, or if the contact was not as close, have them self-observe for 14 days, meaning being particularly diligent about recognizing if they have fever or other symptoms. One of the things we're doing is when we ask someone to self-observe, we provide them with a digital thermometer so they can actually take their temperature and know whether they have a fever. And so that's something your companies might want to do, is to buy digital thermometers that you can give to employees to help with this self-observation or self-monitoring.
Thank you. So the next question is, I'm a caregiver and I live with my elderly parents. What do I do if I get sick because I'm responsible for taking care of the elderly parent? What do I do in that situation?
Yeah, that is a really hard one. I think the best you can do is try to reduce the close contact you have with them. If being close is necessary, to try and take precautions, make sure you wash your hands before you come in contact with them. This is one setting where I'd recommend that you wear a face mask if you can get one, even if you're not sneezing or coughing, because we know that every once in a while a cough just comes up, or even if people are talking forcefully, sometimes you can see the secretions coming out while they're talking. And so in this setting with elderly and frail parents who you're providing care to, just be particularly vigilant about the precautions you can take. If there's someone else who can provide the care, certainly that may be helpful. But a pandemic is really going to put stress on everybody, and so do what you can. Are there other questions?
Yeah, there's one more question. I was just waiting for it to come in. Sorry about that. Hear you. Okay. What environmental steps need to be in place to address workplace contamination from a positive case?
So if a positive, well, let me just take one step back. Before, with a positive case, let's just talk about environmental disinfection generally. So environmental disinfection, more frequently clean hard surfaces, use an EPA list N registered, and frequently clean the surfaces that are touched frequently, like doorknobs and light switches, the buttons on the elevator, things that you think are going to be frequently touched. And so if you have disinfectant wipes, I just encourage you to use those frequently. If somebody has documented infection, their secretions, just like anyone else's, are only going to survive on the surfaces for up to 72 hours. By the time their infection actually has been diagnosed, right? So they have to become ill, and then they have to go to the doctor, and then they have to get the test results. And so by that time, it's likely that the 72 hours has already passed. And so at that point, I think you could reassure people that because of the secretions from that case patient are not any longer an issue for the workplace. Of course, it's always, prudent, and it may reassure employees if you still, do the disinfection and you're particularly rigorous in the areas where that person may have been working.
Well, thank you. And thanks, Dr. Schwartz, for this wonderful presentation. Regrettably, we're out of time for today's webinar, and any remaining questions will be responded to by the speaker. As we close, I would like to remind everyone about our ongoing distance learning opportunities, including upcoming webinars, as well as access to archived webinars that you can access through the AAFA Learning Center. And this is particularly important as now, because AAFA, along with many other organizations, has canceled all of our events through May 31st in light of the situation, and to do our part for social distancing. Also, as a reminder, several of our policy committees are sending out updates on COVID-19 and more. If you would like to join any of those committees, please contact us at membership@aafaglobal.org. We are also sending weekly emails to all members, with the next one scheduled to go out later today. Thank you again to Dr. Schwartz and our President and CEO, Steve Lamar, for this informative session. You will receive an email later today with links to the PDF and a recording of today's presentation. Again, thank you for joining us, and have a great day. Thank you, Dr. Schwartz.